let's start with the very next thing, and that is what's your physiology topic. What important things? Chalo, let's talk about the next topic. Good to go. Physiology. My dear friends, in the CNS part, we'll start. First thing is CNS part. So see, there are 4 type of cells we are having in the CNS: astrocyte, microvilli, ependymal, and oligodendrocytes. What they are doing? Astrocyte is making the blood-brain barrier, and they are made up of tight junction. They are made up of tight junction. Now microvilli, if you see, sir, microvilli, they are the phagocytosis of the bacteria. They will do that. Ependymal cell, they line the ventricle, the empty space in the brain, they are lining the ventricle. Now oligodendrocyte, if we talk about the oligodendrocytes, they make the myelin sheath in the CNS. But who is making myelin sheath in the PNS? That is also your exam question, and that is none other than your Schwann cells, my dear friends. That is none other than your Schwann cell. Dun. Coming to the CSF. Cerebrospinal fluid, total volume 150, daily production 500 ml a day. Secretion is done by S for C for choroid. Absorption is done for A, that is why arachnoid plexus. So daily production 150 ml. Who is producing, secreting? S is sounding like a C. So this is your choroid plexus. Who is absorbing it? A for arachnoid plexus. Equally important to remember for the exam. Ladies and gentlemen, neuron. There will be axon hillock. There will be an axon hillock. If you see the diagram, this axon hillock is going to generate the action potential. Now main ion of this axon hillock is what, sir? Calcium and sodium. Now resting membrane potential is generated from here. Now the action potential main ions are calcium and sodium, and resting membrane potential, the main ions are potassium and chloride. So resting membrane potential of neuron is -70, skeletal and cardiac muscle -90, smooth muscle is sounding like a 5, so this will be your -50. Rods and cones, remember 30, 3 type of cones are there, -30, -40. RBC sounding like a raat ke 12 baje, -12 millivolt. Done. Now potassium and calcium makes the membrane more hyperpolarization. More negativity, more hyperpolarization will be there. Okay, more relaxation will be there. Sodium and calcium are making membrane less negative. That means depolarization is happening. So hyperpolarization, depolarization. So my dear friends, who is doing that? Example, GABA. GABA is an inhibitory neurotransmitter. Glycine is also inhibitory neurotransmitter. Then who is your excitatory neurotransmitter? That is your glutamate. So your remembering of this thing, my dear friend, may God bless you. Remembering of this thing. अगर आपके पास potassium और calcium है, if you are having potassium and calcium, remember they are for the hyperpolarization. And who are hyperpolarizing? They are potassium and chloride. They are for a hyperpolarization, that is GABA and glycine, inhibitory neurotransmitter. Now sodium and calcium, they are making membrane less negative. That means they are for the depolarization. This is glutamate. Now sodium and potassium pump plays main role, and here we have to remember the Nokia. So sodium goes out, potassium comes in. 3 sodium out, 2 potassium in. The sodium going outside will make membrane less negative. Potassium coming in will make membrane more negative. So potassium inside will do hyperpolarization. Sodium outside will do depolarization. They both will use the ATP. So outside create action potential, inside create resting membrane potential. Done and dusted. Now cortical center helps in the memory formation. What we are having for storing of the synapse in the neurocortex. Moment we repeat the things, this is same for the exam also. Moment we keep on repeating the things, the synaptic plasticity is increased, and because of that there will be a short-term memory which is stored in the hippocampus, which is stored in the frontal cortex, will be stored in the hippocampus. So short-term memory is converted to long-term memory in the hippocampus, my dear friends. So this is how we will do. Now the cortical area, auditory we have to 41, 42. Okay. Then speech area 44, 45, which is also called as Broca's area. Then language area is Wernicke's area. We have already talked about all these things. Taste, my dear friends, very important. Taste. Tongue we have talked about. Anterior 1/3 of the tongue we were talking about. Anterior 1/3, the general sensation is done by lingual nerve. Taste sensation is by chorda tympani. Posterior 2/3, there will be glossopharyngeal nerve, and posterior most nerve will be the vagus nerve. Here, what is anterior part doing, what is lateral part doing, what is medial and posterior mode part is doing. Anterior is for salt sensation, my dear friends. So salty is anterior, sour is at the lateral border, bitter is at posterior most border. Done. Again, 𝗵𝗵 is in the center. So salt is sensed by sodium, potassium, sour is by hydrogen and acid, sweet is by G protein, and bitter is also by G protein. So sweet and bitter is by G protein, and 𝗵𝗵, which is MSG, monosodium glutamate, the taste enhancers are there. Chili, mirchi kya hai? Spices kya hai? They are not taste, but they are the pain sensation. So they are sensed by valenoid receptors. Receptors are valenoid. Vanilla ice cream, mirchi lagti hai to vanilla khate ho. Sensation is hot, burning and painful. Now somatosensory system. Sensation from the skin, joint, muscle, etc. pain touch. The first is Meissner's corpuscles. Very important topic for the exam. Meissner corpuscles, my dear friends, remember, right here, where they are present at the tip of the dermal papilla. They are rapidly adapting, this word is very important, rapidly adapting low threshold. Rapidly they adapt, but low threshold pe they will do. This is Meissner's. Fine touch, 2-point discrimination, low frequency vibration. Pacinian is like an onion, high frequency, and they are present in the joint, pressure in dermis and your pressure in your dermis only. Merkel cells, slow adapting touch receptor, help blind people to read. So for 3 types so far we have learned. Rapidly adapting, low threshold, Meissner's. High frequency in the vibration in the joint, that is Pacinian, and your Merkel is slow adapting, that helps blind people to read. Now Ruffini and Kränze. The Ruffini is rubbing part, rubbing we do the warm receptors. Kränze is cold, that is close. They are slow adapting, sense pressure and temperature. Now let's talk about the free nerve ending right here. Free nerve ending, what they do? Pain, temperature, sexual sensation, itching. They are absent in brain and visceral organs. Like stomach, inside it is absent. And they are present in the pain, you will not feel in the visceral organs and inside the brain. They will be present, receptors which are present on the outer surface of these structures. Now 2 types of pains are there, fast pain, slow. Fast is by delta, slow is by C, unmyelinated. Sharp and well localized is a fast pain, dull pain is a slow pain. Now ascending sensory tract in the spinal cord. Sir, anterior spinal thalamic carry what? Lateral carry what, and rest dorsal will carry everything. So anterior side you will be having a itching and crude touch and pressure. Anterior side what you will be having? Itching and crude touch and pressure. Lateral side you will be having a pain and temperature. Lateral rest all will be carried by dorsal column trend. This is also the exam question which was asked in the exam, my dear friends. So remember right here, anterior spinothalamic tract carrying itching and crude touch pressure. Itching, khujli or crude touch pressure aage se. Rest, pain and temperature from the lateral side, and dorsal side rest all sensation it will do. Now lower motor neuron and upper motor neuron injury. Lower motor neuron, the tone goes down. Upper motor neuron, the tone goes up. Muscle tension is sensed by Golgi tendon. Cerebellum, what will do? Basal ganglia, we talk about planning and programming. Cerebellum is coordination and correction of the movement it does. Limbic system is for the emotion genesis. One-liners, just remember for the exam. Now sir, frontal lobe will do what? Frontal lobe will the cognition and control of emotions. Emotion generate to ho gaye, unke control kaun karega? That is done by the frontal lobe. That is done by the frontal lobe. Now hypothalamus function. Different function of hypothalamus. Control the autonomic nervous system, sympathetic, parasympathetic activity. Third center, it will control circadian rhythm, which is inside clock. When day is happening, night is happening. That is inside clock that is happening. That is circadian rhythm, and which is taken care by suprachiasmatic nerve. Hunger center, it is taken care by your hypothalamus. Then temperature regulation in the body. Anterior side of the thalamus will cool the body, posterior will warm the body. Then now coming to the next system called as kidney. So kidney is functional unit, my dear friends. Remember, in the kidney, each we are having 1 to 1.3 million of this nephrons. So remember what is present right here? Efferent and efferent. Efferent and efferent vessels are present. This is Bowman's capsule. Here is a filtration slit. Then there will be proximal convoluted tubule, loop of Henle, ascending and descending. Then there will be DCT, okay, distal convoluted tubule. Then there will be a collecting duct. This is how the kidney function is there. They will be doing the GFR. GFR, they will be taking care of GFR, different type of things we are going to study right now, sir. Now, glomerular capillaries, they are having a filtration slit. How they are made up of, how much size they are. They are having an endothelium and podocytes. They are making a filtration membrane of 4 to 8 nanometers. So, structures which are larger than 8 nanometers are not allowed to pass. Structure which are between 4 to 8 nanometers, they are allowed to pass, but they should be positively charged. And if structure is less than 4 nanometers, they are easily allowed to pass from there. So my dear friends, less than 4 nanometer easily filter. 4 to 8 nanometer depend of charge. If negatively charged, they cannot filter. For example, albumin. This is your previous year question. The size is 9 nanometer, but negatively charged. That is why it cannot filter. Now urine, how the urine formation take place? My dear friends, urine formation take place in filtration, reabsorption and secretion. Now all the substance are first getting filtered in the PCT. Done? They are reaching the proximal convoluted tubule. From there, the good solutes are getting absorbed there and the bad solutes are getting back to the blood. So remember reabsorption, urine to the blood. Good solute like sodium and glucose, they will go back to the blood, and bad solute like your urea, etc., uric acid, they will be secreted through the urine. This is how the urine is formed. So first is filtration. Everyone comes at the one place. Good things are called back, bad things are sent out. This is a basic funda right there, sir. Now coming to the PCT. PCT, what happening here? Maximum reabsorption is happening and maximum secretion is happening. What there is an exception is a max reabsorption but except magnesium, then max secretion except potassium and urea. Now coming to the medulla. Medulla is having a counter current mechanism system. One is medulla is having high osmolality, 1200 osmoles, which decreases with the help of counter current mechanism. What is this counter current mechanism? One is multiplier, one is exchanger. तो ascending loop के अंदर solute क्या होते हैं? Transport, ions add होते हैं यहाँ पे, और exchanger is by vasa recta capillaries which reabsorb the water. पानी बाहर निकलता है, solute अंदर transport होते हैं. This is how the urine is more concentrated now. ज़्यादा पानी की फॉर्म में नहीं होगा, concentrated फॉर्म में होगा. This is called as counter current mechanism. Now DCT. Now DCT में क्या हो रहा है? Sodium and chloride reabsorption by the sodium chloride SIB port, and they are blocked by a diuretic called as thiazide. So thiazide is sodium chloride port blocker. Potassium is secreted by P cells. They are the principal cell, my dear friends. They are the principal cells, my dear friends. Now potassium secretion and sodium reabsorption is by ENaC channel, and they are blocked by amiloride. तो क्वेश्चन 1, thiazide diuretic है, amiloride किसको ब्लॉक कर रहा है? Collecting duct as again has P and I type of cell. P is secreting potassium and I is acidic secretion and make urine more acidic. Make urine more acidic, my dear friends. Now collecting duct has V2 receptor for antidiuretic hormone. Now this is something which is important because you will understand right here what is diabetes insipidus. So my dear friends, what is happening? There is a antidiuretic hormone. Antidiuretic hormone is stopping more water to go outside, and they are having receptor in the kidney, they are having receptor in the brain. So there are two type of diabetes insipidus. One is neurogenic, another is what are your nephrogenic. If the problem is in the brain, it is not getting produced, so this is called as neurogenic diabetes insipidus. And if the problem is in the receptor in the kidney, we call that as a nephrogenic diabetes insipidus, my dear friends. So remember, collecting ducts has V2 receptor of antidiuretic hormone. The ADH is high, water reabsorption will be there and make urine concentrated. ADH is needed to reabsorb the water, so that lot of water should not go outside. If lot of water is going outside, this is called as polyuria. then urge of drinking will also increase. This is called as polydipsia. This disease is called as diabetes insipidus. One is neurogenic, another is nephrogenic. Neurogenic and nephrogenic. Can you anyone tell me what is a drug of choice for neurogenic and what is a drug of choice for the nephrogenic? Then coming to the glucose. Glucose is 100% reabsorbed in the proximal convoluted tubule by which channels? SGLT2 and GLUT2. SGLT2 and GLUT2. Neurogenic desmopressin, correct answer. And what about the nephrogenic? Thiazide, yes. Chalo. Let's move on to this transport maximum of the glucose. What is this transport maximum of the glucose? It's the maximum glucose amount that can be reabsorbed per minute. 1 minute में कितना glucose reabsorb हो सकता है? This is called as transport maximum. How much we can reabsorb? 375 milligram per minute. This is transport maximum of the glucose. Now what is filtration load? Amount of getting filtered per minute. The amount getting filtered per minute in the normal person, the transport maximum of the glucose should be more and filtration load should be less. That is how the all glucose, if you want 100% glucose, so your extracting back capacity should be more than the filtration. The filtration is happening from here and extracting back is happening from here. तो लेके जाने की क्षमता ज़्यादा होनी चाहिए देने वाले से. Who is taking back, that is transport maximum. Who is filtering? Filtration load. So filtration load, if it is less and transport maximum is more, then 100% glucose is getting reabsorbed, my dear friend. If filtration load is more, ज़्यादा रहा है, वापिस नहीं जा पा रहा, then that condition, your glucose will be coming out in the urine and that condition is called as glycosuria. Now what is clearance? The amount of plasma cleared per minute by kidney. The clearance is equal to GFR. If the amount of clearance happening and GFR, it is equal, that means only filtration is happening. If clearance is more and GFR is less, that means filtration and secretion is happening. And if your GFR is more and clearance is less, that means your filtration and reabsorption both are happening. Filtration and reabsorption both is happening. Let's see again how to measure it. Inulin. How to measure this filtration and secretion. Para-aminobutyric acid and creatinine. How to measure this filtration and reabsorption, glucose and amino acid. Now again understand, clearance is equal to, how much is getting clear is equal to the GFR. Okay? Now clearance is more but GFR is less. That means the clearance is more, GFR was less. Now this is coming wala part, this is secreting wala part. Now GFR was less, still वो वहाँ से ज़्यादा कैसे निकला? It's मतलब कुछ उसको अंदर डाल रहा है, तो फिल्टर के साथ साथ सिक्रीशन भी हो रही है, कहीं से अंदर आ रहा है. अब क्लियरेंस कम है, GFR ज़्यादा है, आ ज़्यादा रहा है और निकल कम रहा है, तो रास्ते में कोई उसको ले रहा है. That is called as reabsorption. That is called as what, sir? Reabsorption. Now coming to the GFR part, most accurate method is inulin. Most commonly used is what, sir? Your creatinine. Done. Now renal plasma flow is estimated by para-aminobutyric acid. This is again a one-liner question you have to remember for the exam. Coming to the next part is juxtaglomerular apparatus. This juxtaglomerular apparatus is having three types of cell. One is JG cell, 𝗲𝗲 cell and macula densa. Now this juxtaglomerular cells are present on the afferent arterioles. तो ये signaling देता है कि flow ज़्यादा है कि कम है. This 𝗲𝗲 cells will do the phagocytosis and macula densa will regulate the GFR which is present on the DCT, my dear friends. Now this juxtaglomerular cells, they are present on the afferent arterioles as I told you. They sense the renal blood flow which should be 1250 milliliter per minute. If the flow is poor, renin release होगा, RAS system activate हो जाएगा. This is how it is going. So juxtaglomerular cells, they are present on the afferent arterioles. The normal renal flow is 1250 milliliter per minute. If the flow is less, they will ask renin to get released. Moment the renin is coming, the RAS system is activated, in which reabsorption will take place. ठीक है? चलो. Now let's talk about the next system, which is respiratory system, sir. In the respiratory system, you remember inspiration, expiration, what muscles are used in the inspiration, what muscles are used in the expiration, forceful expiration and etc. Now inspiration is an active process. जब हम सांस अंदर लेते हैं, this is active process. This needs active involvement of the muscle. So the muscle use are diaphragm and external intercostal muscles. For the inspiration, which two muscles are there? For inspiration, two muscles are there, that is diaphragm and external intercostal muscles. For the expiration, which is a passive process, sir, this is due to the elastic recoil of the lung. No need of any muscle. Now forceful expiration, if you have to do, normally it goes because of the elastic recoil. But if forcefully you have to send, then you have to use the abdominal muscle and internal intercostal muscle, my dear friends. Now I will ask you some questions and you will answer right now, sir. No muscle is used for normal expiration. Now second question is internal intercostal muscle is used for forceful expiration, external intercostal muscle is used for inspiration, abdominal muscle is used for forceful expiration, and diaphragm is used for inspiration. Very, very good. Now let's talk about the intra-alveolar pressure and pleural pressure. Sir, this is visceral pleura, this is parietal pleura. The space between visceral pleura and parietal pleura is intrapleural pressure here we having, and which is inside the alveoli, it is intra-alveolar pressure. So intra-alveolar pressure is this pressure we are going to talk about. At rest it is 0. During inspiration it is -1. End of inspiration again becomes 0. And sir, during expiration it become +1. So how the inspiration happens? If examiner is giving you question in the exam and is asking you ki steps likho. First of all, muscles contract, then expand the thorax. Muscle contracts, expand thorax, negative pressure is created and air is entering inside. Now intrapleural pressure, we have to talk about this pressure. What is between the visceral and the parietal pleura? Sir, at rest this is going to be -2 mmHg. At rest this is going to be -2 mmHg. Normal quiet inspiration -6. Normal quiet expiration -2. So it never becomes 0. So what is the significance that it never becomes 0? That it will prevent the collapse of lung. It will prevent the collapse of lung. It will prevent the collapse of lung. Lung को collapse होने से बचाता है. Now forceful inspiration is -20 mmHg and forceful expiration is +20 mmHg. So these are some one-liner values you need to remember. Intrapleural pressure is always -2. Why? Because it prevents the lung from collapsing. Now second is compliance, that is stretchability of the lung. How we'll calculate? Change in volume upon change in pressure. The change in volume upon change in pressure, sir. The change in volume, that is delta V upon delta B. Now restrictive lung disease, the lung become fibrous, the stretchability compliance is gone. The volume become very less. And obstructive lung disease, you will have problem in the expiration. Stretchability is there, compliance is not there. So obstructive lung disease, good compliance, poor recoil. Compliance is good. Good compliance is there, stretchability is there, but recoil is poor. That is obstructive lung disease like emphysema. Now we'll talk about how the airflow is changed in the restrictive lung disease and how airflow is increase or decrease in the restrictive lung disease respectively. Now let's talk about the surfactant. Surfactant is produced by MCQ, that is type 2 pneumocytes and Clara cell. Again a previous year question of your exam. What is the function of surfactant? Decrease the surface tension, my dear friends. Now 70% they are secreted by 70 dipalmitoyl phosphatidylcholine, which is having lecithin and sphingomyelin. In the normal surfactant, this ratio should be more than 2. Ratio should be more than 2, my dear friends. Ratio should be more than 2. The production start at 18 weeks of life. The production start at 18 weeks of fetal life. Then, sir, the secretion and action inside the alveoli starts at 28 weeks. Max secretion and function start at 34 weeks. Sir. These are the 3 important things you need to remember for the exam. Now, sir, remember lung volumes. Tidal volume, the normal air which we are inspiring, that is 54, inspiration. Inspiratory reserve volume, IRV, 3 to 3.5 liter, very important volume. Expiratory reserve volume is 1.3 and residual is always 1.2. Now lung capacities, we mix certain volumes and we make the capacities. How we are making that? Let's see. Inspiratory capacity IRV plus TV. The inspiratory reserve volume was 3 to 3.5 plus total tidal volume, that is 500. So this is 3.5 to 4 liter. Expiratory capacity is ERV, expiratory reserve volume plus tidal volume, that is 1.3 to 1.8. Functional FRC, functional residual capacity, this is ERV plus RV, that is ERV plus 1.2, RV plus 1.2, that is 2.5. Vital capacity, sum of all. Inspiratory reserve, expiratory reserve and tidal, in male it is 4.8, female it is 3.2 because of the adipose tissue. Now this spirometer cannot measure the RB, so FRC cannot be given on the spirometer. So FRC is equal to ERV plus RV, because ERV plus RV ka mixture hai. So if RV is not there, you cannot calculate FRC. So FRC can be measured by other method. Those are helium dilution method, single breath nitrogen washout method, which is also called as Fowler's method, and plethysmography, which is done in the OLD patient. OLD, that is obstructive lung disease ke patient. Now I was telling about restrictive and obstructive lung disease, how the volumes differs in all these cases, my dear friends. Now vital capacity in the restrictive lung disease where lung fibrosis has happened will decrease for sure. Obstructive lung disease where compliance was present but recoil was not. So volume can be normal depending on the disease and can be increased. Done. FEV1 percentage. What is this FEV1 percentage? The amount of air which is coming out from the lung in the very first second. Again I want to repeat. The amount of the air coming out from the lung in the very first second is FEV1%, 2%, 3%. The 1%, 75 to 80%, 95%, then 98%. So my dear friends, in the restrictive lung disease, this FEV1 percentage will be normal because your outgoing capacity is not again hampered. But in the obstructive lung disease, remember there is an obstruction in going outside because recoil is not there. Compliance is there, वापस नहीं आ पा रहा तो बाहर, इसीलिए it will be reduced. Inspiratory reserve volume in the restrictive where lungs are small, decrease. OLD can be normal, can be increased. Residual volume, you will see in the restrictive lung disease will be decreased. And obstructive lung disease, the residual volume where the lung is becoming big like in emphysema, it will be increased. So make sense, make logic. Total lung capacity, mixture of all, my difference, approximately 7 liter is going to be there. This is again a same chart where inspiratory reserve volume and all those things you have to see. So the 500 ml of tidal volume is coming out inside. How much is stuck in the anatomical dead space and how much is getting exchanged? So in anatomical dead space, it is 150 ml out of 500 and 350 ml it is getting exchanged, my dear friends. Okay, chalo. VQ ratio, the coming in air coming in for exchange versus blood coming in for exchange. So blood on the base of the lung will be more as compared to the apex. One thing, air will be more at the base as compared to the apex. Done, sir? So remember, the ideal VQ ratio is 1, not -1. Normal VQ ratio is 0.8. Apex pe VQ ratio will be high. There will be a mismatch in the air coming and the blood coming because poor perfusion will be there on the apex of the lung. So poor perfusion is the region. Base of the lung is having minimum this exchange gap, that is 0.6 because of the high perfusion. The mismatch is less, that is why VQ ratio at the base is less, which is 0.6, and they are high at the top, which is 1.3. Now sir, gas exchange depends on 3 factors. What are those? Membrane, partial pressure and part of the gas. Henry law is important law for the exam. Now partial pressure of O2 depends on dissolved in oxygen, not hemoglobin bound oxygen. So oxygen which is present in the body, जो हमारी body के अंदर oxygen है 2 form में है, एक dissolved form में, एक hemoglobin के ऊपर है. तो जो dissolved form में that is only 1% and जो hemoglobin के ऊपर है, 1 hemoglobin molecule carry 4 oxygen molecule. 1 hemoglobin carry 4 oxygen molecule. Or 99% will not decide the partial pressure of the oxygen. The who will decide? Only 1%. This is what called as Henry's law, my dear friend. This is called as Henry's law. And now this question is going to come in your exam. You have to pay attention right now, sir. Now this is oxygen hemoglobin dissociation curve. Now if the curve is going to the left side, so L for Haldane is there. Now this blood is going to the lungs. So lungs के पास जाएगा तो what it will carry? It will carry oxygen. So if it is going to the left side, oxygen is high. Oxygen के साथ साथ में your pH will be high, rest everything will be low. You can see right here, sir. If it is shifting to the right side, this is going to be the Bohr's effect. So right side blood is going to the tissue. From tissue it will carry the oxygen. It will carry the carbon dioxide. So remember, oxygen and pH will be low in case of Bohr's effect, rest everything will be high. And here when it is going to the lungs, here pH and oxygen will be high, rest everything will be low. Everything will be low. Done, done. So you understand this thing? Haldane is left side, Bohr is right side. Haldane is left side, Bohr is right side, my dear friends. Now pacemaker of respiration. Who is a pacemaker of respiration? This is pre-Botzinger complex. Now pons is making the respiration and medulla is, maintaining. Pons is like a papa. Papa maintain, mama make. Medulla is like a mama, mama make respiration. तो अगर medulla पे lesion हो गया तो no respiration. अगर pons पे lesion हुआ पापा वाले तो irregular respiration because pon is maintaining the respiration. Now coming to the carbon dioxide. They act as both peripheral and central receptor. That is why they are main stimulus for the regulation. Not oxygen. Who is the main receptor? Remember, that is your carbon dioxide. Now coming on to the next system, that is your cardiovascular system, my dear friend. Remember, the pacemaker is SA node, which is having the max frequency, slowest conduction at AV node, fastest as per FMGE fiber. Now cardiac cycle, just keep it aside. Heart sounds are important. All four heart sound. Yes, let's talk about that. My dear friends, S1, S2, S3 and S4. Let's talk about all these heart sounds. When the AV valve, atrioventricular valve closes, S1 is produced. Semilunar valves are closed, then S2 sound is there. Early diastole, S3. Late diastole, there will be S4. Late diastole, there will be a S4. So I'll ask some question. S1 is produced when? S2 is produced when? S3 is produced when? जब ventricular filling होती है early, that is S3. जब late filling होती है, that is S4. Now let's talk about this JVP. A, C, X, V and Y. 4 X's are there, sir. 5 X's are there, sir. Remember their significance, you have to remember for the exam. So here you will remember A for atria contract, C for ventricular contract. Sir, A for atria contract and C for ventricular contraction is there. A for atria contract, C for ventricular contract, X for relax, atria, relax. A for atria contract, C for ventricular contract. AC, atria contract, ventricular contract and X for relax, atria, relax. V and Y. V कहता है atria fill हो रहा है, Y कहता है ventricular fill हो रहा है. So these are the 5 things you have to remember for the exam. A is atria contract. Then coming to C, ventricular contract, X atria relax. Then there is V and Y. V stands for atrial filling, Y is ventricular filling. Y is ventricular filling. Done. Now volume, end diastolic, stroke volume, ejection fraction and end systolic volume. My dear friend, end diastolic volume is 120 to 130 ml. Stroke volume is 70 to 80 ml. Ejection fraction is stroke volume upon end diastolic volume multiplied by 100, that is just 65%. And systolic volume, which is always inside the heart, that is end diastolic versus minus systolic volume, that is 40 to 1. So stroke volume is important, which is 70 to 80 ml. 70 to 80 ml, my dear friends. Cardiac output depends on that. That is stroke volume, which is 70 to 80 ml multiplied by heart rate, that is 70 to 100, that is 5 liter per minute. So how much cardiac output normally we have? This is 5 liter per minute. Frank-Starling law will tell you about the inotropic shift. If it is positive shift, cardiac functions are decreased, it will go up. If it is decreased, it will go down. Now let's talk about the next topic also, coronary blood flow, my dear friends. Coronary blood flow. So max in the diastole, minimum in the systole, and max cross-sectional area is present in the capillary. This is present previous year question for your exam. Sir, coronary blood flow normally is 250 ml per minute. Max in diastole, minimum in systole. Max cross-sectional area is present where it is your capillaries. Type of vessel is an important previous year question you need to remember for your exam. My dear friends, The type of vessel, number one is Wind-Kessel vessel. The first type of vessel is going to be what? Your Wind-Kessel vessel. It is a large elastic vessel, has an elastic recoil. Large elastic vessel has a large elastic recoil. Example is aorta. Aorta is an elastic recoil. It also give a pressure to the blood. Capacitance vessel means they are storing the blood. So maximum it is with the systemic veins. How much they are storing? It is 50 to 60% of the blood, my dear friends. Who is exchanging? Because they are having the max cross-sectional area. None other than your capillaries. Now resistance vessel, which are deciding the BP, hypertension, those are the muscular arteries and the arterioles, my dear friends. Muscular arteries and the arterioles. So my dear friends, what is fourth power effect? Very important. If we increase radius by 2 times, the resistance will decrease by 16 times. Decrease by 16 times. This was question asked in the exam कि अगर आप रेडियस को दुगना करते हो तो कितनी रेजिस्टेंस कम होती है? This will be 16 times reduced in the resistance. Now coming to the next, regulatory centers which are present in the medulla, my dear friends. Regulatory centers. If we talk about the regulatory center, the medulla is having 2. One is vasomotor center, VMC, another is cardiovagal center. Sir, this vasomotor center is like a victory. Victory is increasing heart rate, cardiac output and BP. Now cardiovagal center is cutting, they are stopping. So remember, decrease heart rate, cardiac output and BP. So there should be a center who is increasing and there should be a center who is decreasing. तो एक बढ़ाने वाला है और एक कम करने वाला है. तो बढ़ाने वाला कौन है? VMC, victory. काटने वाला कौन है? CVC, that is cardiovagal center. Now baroreceptor, what their function is? They act as a brake. CVC को कब बढ़ाना है, VMC को कब कम करना है, they will be decided by the baroreceptor. Where they are present, that is also very simple question. So aortic baroreceptor and carotid baroreceptor. The aortic are present at arch of aorta, that is A. Answer, carotid is present at bifurcation of common carotid artery, that is CCC. Function, they act as brake. How you will apply the brake? जो कम कर रहा था, CVC was decreasing cardiac output, heart rate and BP. ठीक है, cardiovagal complex. We will increase the cardiovagal complex and we will decrease the vasomotor complex. You can write, see them. So cardiovagal and vasomotor complex, how we will increase and decrease. Baroreceptor, where they are present, we have just saw, because this is also previous year topic. Now coming on to the next system called as GIT. So far so good. I know some subjects we don't feel like studying, etc. But these are some very important questions you need to do before that. No skipping. हो सकता है मन ना हो कभी पढ़ने का, हो सकता है कभी समझ में भी ना आ रहा हो सकता है कभी मन करे कि छोड़ देता हूँ. So sometimes you have to put extra effort like we are putting onto these subjects. जो छोड़ना मना है. Within R will compile it. Within R will compile. Within R we compile anatomy. Within R will compile the physiology and other subject like 1R will compile it. Now the 4 layers of GIT. What is that? Mucosa, submucosa, muscularis and serosa. Mucosa is having villi and microvilli. What they increase the area of absorption. Second is what, sir? Your submucosa. Submucosa में sub है blood vessel, nerve, lymphatic, glands. Muscularis is different for the peristalsis. Serosa is for attachment and stability. Now this serosa is absent in esophagus. Rest peritoneum organ, it is present, but it is absent in esophagus. So what is present in, which is a 4th layer present in esophagus? Your answer is adventitia. Your answer is what, sir? Your adventitia. Done. Now GIT functions are controlled by enteric nervous system, whereas parasympathetic and sympathetic. Parasympathetic receptor goes with M1, M2, M3 and 4, which we'll talk in the pharmacology session also. Sympathetic go by alpha beta receptor. Now pacemaker of GIT. Who is a pacemaker of GIT? It is your intestinal cell of Cajal. So Cajal cell will be generating a basic electrical rhythm with the stimulus of food. After that, spike will be coming and then calcium will increase. That will activate calmodulin. And calmodulin के आने से myosin light chain kinase will be activated and it will break ATP and there will be a contraction. This is how the peristalsis is happening. Now, what are the type of GIT movements we are having, my dear friends? One is peristalsis, moves the bolus outside. So who is dilating and who is constricting? Just remember who is dilating. Sir, nitric oxide and VIP, they will dilate it, और पीछे से rest everyone, serotonin etc. acetylcholine, they will be contracting. आगे से खुलता जाएगा, पीछे से बंद होता जाएगा, खुला बंद हुआ, खुला बंद हुआ, खुला बंद हुआ. This is peristalsis. This is what, sir? Peristalsis. Now, reverse peristalsis happens in vomiting. Migratory motor complex, also called as broomstick of the abdomen. Also called as broomstick of the abdomen. They are produced by an empty stomach. जो छोटा छोटा अंदर सामान रह गया उसको निकालने के लिए, that is why this is called as broomstick of GIT. They prepare GIT for the next meal. We feel like good आवाज, that is 90 to 100 minutes it will happen. Mass movement is for the defecation, my dear friends. Mass movement is for the defecation. Normal 3 times a day, more than 3 times we call that as diarrhea. Now, pacemaker of defecation is ganglionic cell of colon. They are formed by the Auerbach's plexus. If it is absent, the disease is called as megacolon. Now, some one-liners for all of you. Maximum potassium concentration is going to be C for C, colon. Potassium secretion, S for S, saliva. Max GIT secretion is going to take place in the intestine. Max GIT secretion, minimum GIT secretion is bile. Most acidic, gastric, alkaline, pancreatic. Brunner's gland are present at duodenum. We already have studied in the anatomy session also. Now, parietal or oxyntic cell, they will produce HCl. HCl will convert pepsinogen into pepsin. Pepsinogen into pepsin, they help in the fat breaking. Now, mechanism of HCl secretion is also very important. Carbon dioxide और पानी को mix कर दो तो carbonic acid बनता है. Now, this carbonic acid में से 1H will be here, rest of the carbonic acid will be replaced by chloride. So, here chloride is coming, here H is coming, so HCl is made. Most potential colorectal, they are helping in this contraction of the gallbladder. The bile salt is better answer than the bile acid. This is also your previous year question. Now, general physiology is the last topic we are going to do in the physiology. Now, let's talk about this general physiology. In this, very important thing to remember is glute wala part. This, I would love to cross it here. We will again discuss in the biochemistry part, sir. Now, important thing I want to tell you right here, let it be, is important thing is total body water. Sir, the total body water is going to be the 60%, that is 36 liter of the 60 ml. 36 liter of the 60 ml. Now, how we will divide it, sir? How we'll divide it? We divide it into intracellular and extracellular fluid. जो अंदर का आदमी है out of 36 is getting the maximum benefit, that is 24, that is your 24. Remaining extracellular fluid is बाहर का आदमी getting only few benefit, that is 12 liter. Now we divide this into 3 plus 3 plus 3 plus 3, sir. Again we are dividing this into what, sir? Your plasma and interstitial fluid, sir. Plasma and interstitial fluid. Now plasma is 1/4, that is 3 liter only. Interstitial fluid अंदर का आदमी getting 3/4, that is 9 liter only. So this is how your blood volume is divided. ICF, ECF. First of all, if we take a 36, 2/3 is going to the ICF, अंदर का आदमी, 1/3 is going to be the ECF. Then ECF is divided into 2, plasma and interstitial fluid. Plasma is getting 1/4, interstitial fluid is getting 3/4. Done. ठीक है, चलिए. Now dye dilution method. $1.5 दान दिए किसी ने मेरे को. Dye dilution method for the volume estimation. The total body water is measured with the help of deuterium and tritium. Extracellular fluid is measured with the help of inulin and sucrose. Plasma is measured with the help of technetium 125 and 131. ICF is measured total body water minus extracellular fluid. Done. Active transport. Sir, active transport is against the gradient and they use the ATPs. For example, sodium potassium pump. Now it is further divided into 2. One is, what is that? That is primary active and secondary active. Primary will use the direct energy, like example pump, sodium potassium pump. Now the secondary active will use energy, but indirectly it will use energy. So they need a sympoters. So this question has been asked multiple times. Sympot word when it is used, this is example of a secondary active transport. So my dear friends, secondary active transport, indirect use of energy, for example, sodium glucose symport, sodium amino acid symport. So who is this symport supporter? that is your sodium, sir. Coming on to the passive transport, that is along the gradient, no energy required. For example, osmosis, diffusion, no energy required. कोई भी energy इसमें required नहीं है.